Thank you, Deanna, for that. Thank you for the introduction. And as you said, I'm going to be discussing a qualitative study of patients' views and experiences while using the eye catcher, which is a home-based visual field test, which my colleague Pete just discussed in the previous talk. A very brief introduction to those of you who don't know much about glaucoma. So glaucoma is a chronic progressive condition, and unfortunately any sight lost through glaucoma is not recoverable. Diagnosis and monitoring of glaucoma is based on the appearance of the optic nerve head. So here we can see a picture of a nice healthy looking optic nerve head and one that's suffered with some glaucomatous damage. We also measure the intraocular pressure within the eyes and assess the patient's peripheral vision, so how well they're seeing around the edges. Glaucoma is the second most common cause of certified vision impairment in the in England and in Wales, and it estimated that it affects about 500,000 people in the UK. There's an increased prevalence with age, so we're estimating that around 2% of people in the UK older than 40 have chronic open-angle glaucoma, and this rises to about 10% of people over the age of 75. Patients with glaucoma have problems with the periphery of their vision. So patients who are, for example, viewing this slide might see the center text very well, but will have problems seeing around the edges. And this has obvious implications for their day-to-day life. Once a patient is diagnosed with glaucoma, they require lifelong monitoring, and this can be burdensome for both the patient and the hospital eye care services in terms of time for the appointments and cost as well. And this is only due to increase, partially due to an aging population. The more people that have glaucoma, the more people we have to treat and see. Partly because primary eye care are getting better at diagnosing eye diseases, which is excellent that our optometrists are getting better at diagnosing conditions, but this does mean more referrals into the system. And there's also cause for increased monitoring. So studies have shown that intensive visual field monitoring can help identify and prioritise individuals most at risk of sight loss. But our healthcare systems currently can't cope with the capacity for repeated multiple testing within a year. And we need to think, if we're asking our patients for those extra tests, are they going to have to come in for extra appointments? We also have the more recent effect on our clinics of COVID-19. This has reduced our hospital eye care clinic availability, as it has for all hospital eye care services, but it also has psychological implications for our patients. So these patients may be the ones who have been told they have to isolate, then avoid busy settings. So how are they going to feel about coming into a crowded eye care department? And are we going to be able to social distance with the amount of patients we're seeing? When we look at the visual field, we do so by measuring it through perimetry. So the output of a perimetry test gives us an idea of how well the patient is seeing in the periphery. And the gold standard for that used in hospital eye care departments is the Humphrey Field Analyzer, or HFA. You can see a picture of one here, and you can see that it's not really the most adapted for home monitoring. It's big, it's bulky, and it's also quite expensive. Home monitoring then is a possible solution. It's already been established for conditions including high blood pressure and diabetes. And in healthcare is already under investigation for macular degeneration. Ruth Hogg will be giving a talk on this after. And several tablet-based devices and head-mounted displays have been developed to measure visual fields away from a clinical setting. We used iCatcher, which was developed by Dr. Pete Jones, an excellent researcher within our department, and we uploaded this to a laptop tablet device, which you can see here. Pete discussed this earlier. The advantages of this is that it's low cost, it's portable, and as Pete's discussed, it's comparable to the Humphrey Visual Field Analyzer. It also has an output which is familiar to practitioners, which I think is really good. We're not going to have to learn a whole new set of interpretations. So the objective of this particular arm of the research was to explore the acceptability of the home visual field testing using iCatcher among people with glaucoma over a 6-month period. I won't go too much into the methods and how we collected our data. Pete's already gone through that previously. But it's worth noting that patients weren't cherry-picked for this particular study. So the first 20 people who contacted us who were eligible for the study and who were able to attend were the ones that were chosen. We didn't, for example, pick our patients based on how good they were with computers. So after their initial visit to the Cityside Clinic and having 6 months with our device, the patients returned to the Cityside Clinic again, undertook a final Humphrey visual field test, and we got some qualitative data collection from them. And this was in the form of a semi-structured interview. So a semi-structured interview uses questions which have been pre-prepared. So every participant will receive the same set of questions. However, if they wish to bring up something that wasn't covered by our questions, something they feel is particularly interesting or important for us to know, then we'll capture that data also. Our questions were based around 3 themes: capabilities in using the eye catcher, their motivations to do so, and reflections on how we could optimize this for the future. Interviews were on average about 17 minutes long, and some were up to 40 minutes long, and they were recorded and then transcribed. InVivo software was used to analyze the transcripts, which were read and reread to ensure familiarity with the data by the 2 authors. And then we looked for meaningful units of text, which were coded by the 2 authors independently. A third reviewer also reviewed the coding before the entire research group came together and discussed the framework. During this discussion, coded texts were examined and patterns were labelled under different themes. We then created these themes, put them together, and looked for sub-themes within these also. We also did a member check to ensure validity of our analysis. So participants who had taken part in the research and who had agreed to be contacted were given a copy of our analysis, what we found, and were encouraged to provide any feedback to us to ensure an accurate representation of their experience and views. And this is really good. This is a really good thing to do. It makes sure patients and participants feel very much part of the research, and also ensures a transparent and robust analysis. So what did we find? So we coded and found 4 main themes: capability, comparison with the Humphrey, motivations, and practicalities for wider implementation. And you can see that coming from those themes were our sub-themes. So for example, when we're looking at practicalities for wider implementation, patients discuss things such as data transfer and the frequency of testing. So let's look at what our patients actually said about doing this at home. Well, thankfully for us, they were highly capable of completing the series of monitorings that we were asking from them, and did so with a high level of confidence. So this quote captures that quite nicely. I thought it was fairly straightforward to do. I've done quite a few visual field tests in my time, so it was just like normal to me. So patients were familiar with doing a visual field test, with the process that that involves, and they were also familiar with using laptop-based devices. Some participants described how their capability was impacted by difficulties in ensuring the testing conditions were appropriate and repeatable. And that's something which we could have perhaps focused a little bit more on in the instructions. As Pete explained earlier, all the tests were completed to a good standard and the data were usable. So if in future we would update the instructions to reflect this, then that might not be something that would worry the patients in future. In general, the instructions were clear and were well regarded by the participants. There were some technical difficulties experienced by 1 or 2 of our participants, and whilst they didn't find that problematic themselves, they were aware that other people might not find these quite so easily remedied and might not be quite so confident in overcoming these issues. When comparing using the eye catcher device with Humphrey Field Analyzer, they liked using our device. This pleases us, obviously, and there were 2 main themes around what they found useful. So the first quote I'm going to read here is from a patient regarding the testing position. So this patient said that they found Humphrey very difficult. It never seems possible to get my chin, body and head in the right place. So I'm always left feeling very uncomfortable during the test. So the fact that it could be done at their own chair, at a dinner table, no headrest was used, made patients feel a lot more comfortable. The other thing to focus on was the testing environment. So we know that testing environments at opticians and in healthcare services are very busy. This background noise and distractions from other people having their tests done can affect the patient and their confidence doing the test. So the fact that they could do it at home, in their own time, in their own place, they felt was better. The motivations for completing the visual field test sometimes were based on the patient specifically, and sometimes were based on the wider benefit that they could see. So eye catcher was seen as being able to facilitate more frequent testing, which patients equated with closer monitoring. A lot of these patients are usually having a test perhaps once every 6 months, once every year, and that isn't as frequent as they may like. So they liked the fact that if there was a sudden change in the vision, they could get to their consultant quicker rather than waiting the 6 months that they would have to. It was less burdensome. They didn't have to arrange to have people take them to the appointment, arrange for taxis, take time out of their day for that. And as the data would be collected from home, patients were looking into how much of a cost saving this could be to the NHS. Although we didn't conduct an economic evaluation of this, so we can't say exactly how much money this would save the NHS, if there are less examinations done at the NHS, shorter appointments, then it stands to reason that it potentially could save money in the long run. Home monitoring also gave participants a sense of empowerment and control over when they could complete their tests, and that gave them a sense of control over their condition. When we think of the practicalities for wider implementation, some interesting points were brought up, and the first is one that's really important with regard to data transfer. So this participant asked, how is the data on the device going to be communicated? Will that be done in real time, and how will that information get to the hospital? This is a really important point, and one that does require further investigation. If visual home monitoring was more widely implemented, would it be a virtual update to a consultant? Would it be a printout that the patient would take? How would it form part of their standard care? Participants also wished for more feedback. So one of the things with home monitoring is you're never quite sure if you've done the test well, and you're not necessarily sure of the results. So patients, some of which would like access to their data, and some of which would like feedback. So that could include just seeing their own printout. It could mean that they just get some feedback automatically from the programme to say that they'd completed the test successfully. And it's also worth noting that for some participants, completing the visual field test on a monthly basis was too much for them, and we certainly don't want this to become a burden to our patients. So although this was a research study and this was what was appropriate for that, we should see this as an opportunity to individualise and customise our eye care for our patients. So, to discuss, participants welcomed the opportunity to complete more regular tests, as they felt this was contributing to a closer monitoring of their glaucoma. And this gave them confidence that any deterioration in their visual function would be identified more rapidly, and this provided comfort and reassurance, particularly for those that are going longer visits without seeing their practitioner in the hospital. It's worth noting that delayed follow-up due to hospital-initiated appointment rescheduling, which happens, has been reported as a cause of visual field loss in some patients with glaucoma. So this might alleviate the stress that patients may feel regarding this as well. Patients appreciated that they had more control over internal and external distractions, so they could complete the test at a time which suited them best, allowing them to concentrate fully on it and giving them their peak performance. And that greater responsibility that home testing provided was empowering for some patients, and so they thought that it might encourage a more sustainable approach to living with their glaucoma. I think we need to carefully consider our instruction, and actually some of the problems that the patients presented with us during the analysis could be overcome by just updating the instruction that we give them. Though implications for future research, I think the take-home message from this pilot study is that the use of a tablet-based perimeter for home visual field testing was feasible and widely accepted amongst our group of people with glaucoma. And it potentially has time and resourcing savings to both patients and the NHS, and this was viewed positively. However, it's worth noting that the extent to which home monitoring is cost effective is yet to be established, so that's something that needs to be researched. It also gives us as a clinician a more quality orientated approach towards our patients. We can discuss individual monitoring with them. So some patients, we may decide we ask them to monitor once a month. Others maybe once every 6 months or once every couple of months. It doesn't need to be a standard that's set out. It can be discussed so that it's appropriate for the patient and the practitioner. The transfer of results really needs to be looked into. This is something that we need to develop a scheme for if this is going to take place, if people are going to monitor at home. I think these results need to be able to get to the practitioner who's monitoring the patient. So I think that's something which needs to be considered and discussed. I would like to say a huge thank you to the team that I worked with on this study. Amazing, all of them, and very much a big thank you to our participants who gave up a lot of time for us and provided us with invaluable feedback. A big thanks I would like to also give to Glaucoma UK, who funded this project in the first place. Thank you, and I would like to take any questions.
Thank you, Tamsin. That was fantastic, and it's so important to hear about participants and patients' views, isn't it? So really important work. We've had some great questions on the chat, so I'll read out a few again, just going for the ones with the most votes. So if we start off with, is the software clever enough to adjust the stimulus size to account for different distances from the screen, ensuring stimulus size remains constant on the retina?
That's perhaps more of a question for Pete's previous talk. The distance that we set for our participants, we set and measured out for them, so they technically should have been at the same point. However, using the camera, we are able to tell whether they were sat at the same distance and whether they maintained that distance. So different distances from the screen shouldn't be too much of an issue. We could always edit that post hoc. With regarding to seeing in the same size in the periphery, I'm not quite so sure about that. I'd have to ask Pete.
Okay, and another question on the kind of technical side of the test. How far into the periphery can be tested with it?
That's a good question, and I do know that it's a 4x6 grid, so it's the central 24/2 of your Humphrey field analyzer, and obviously by adjusting the distance we could potentially test further out.
And how did you instruct patients regarding the position of the laptop screen? The person who's asking has just pointed out that changes in the angle of the screen can affect the brightness, as well as differences in distance from the screen having an impact from test to test.
Yeah, so as I say, the differences in distance we can actually take into account afterwards, although looking at the camera data, it seems like patients were pretty strict on where they were. Background lighting actually was something that we instructed participants to do it in dim lighting. We wanted it dark enough to not provide too much distraction, but obviously we were recording them, so it couldn't be done in the dark. And there were some patients, as I alluded to earlier, that were concerned about keeping that the same throughout the 6 months of tests. But actually, when we looked at the data, the changes in luminance in the background didn't make any difference to the overall result. So that's something that perhaps needs to be communicated more to our participants, so that's not a source of concern for them.
Right. And one final question. Jasleen Jolly said, very interesting work. And how do clinicians react and accept the data that's being generated?
If we're talking about, are we talking about future? So if this was to be implemented, I guess. Yeah, I think that for myself, how I see it going forward, I think the most ideal solution would be that there would be some way that the data could be transferred, perhaps through NHS Net or something, and that practitioners who are looking after their patients could be seen in real time. so they could be uploaded as the test is done. It could be that they're printed out at the patient's home and taken along, but actually I think if there's some way that we can get those results straight away to our practitioners, that would be the best bet. But obviously I don't underestimate the amount of work that would take to do that, having worked with those sorts of programs in the past.
Brilliant. Thank you, Tamsin.
Thank you, Deanna. Thank you.